We'd like to begin this session. Healthcare reform in the U.S. economy. Welcome all to the Aspen Ideas Fest. I'm Laura Liswood. I am the Secretary General of the Council of Women World Leaders, which is a public policy program at the Aspen Institute. Again, I would like to welcome you all to this, what will be a very interesting session. My role is to both welcome you and to introduce your moderator, Jonathan Cohn, who is the senior editor of The New Republic. He writes about national politics and its influence on American communities. He's the author of a very popular and timely book, Sick, The Untold Story of America's Healthcare Crisis and the People Who Pay the Price. You've probably read some of Jonathan's byline in either New York Times, Washington Post, Newsweek, Mother Jones, Rolling Stone, Slate. So he has quite a wide and eclectic writing perspective. I also asked him if he could tell me something else about himself that we wouldn't know from the bio we received. And he says he's a pursuer of impossible dreams and not only reflecting on health care, but he told me he is a fan of the Boston Red Sox. Jonathan, to you.
It's getting pretty fun. I have great faith in lost causes. It's really not fair. Well, thank you all for coming. This turns out to be an incredibly auspicious moment. Very good timing to be talking about health care. Most of you know Congress is out of session at the moment. We're glad to have you here for that. But they're going to be back next week, and they're going to be working very hard on trying to get a health care bill passed this summer, get it out of each chamber, and so that come the fall they can get together and vote on a final version together and actually produce something that most people would say is impossible, a piece of comprehensive health care legislation signed by the President of the United States before this year is up. The reason we're at this moment, most of you know this, I assume, is that we have a big problem with health care in this country. Health care is extremely expensive. It's costing more and more. There's a drain on our government. Within a few decades, the federal government will become a giant health insurance company that on the side runs the Army and watches the environment a little bit. It is a drain not just on our government, but on our society as a whole. It is gobbling up more and more resources, and there is a lot of evidence to suggest this is not money well spent, that we are throwing good money after bad on treatments that don't work, are ineffective, and we waste an incredible amount of money in our healthcare system. And, of course, it is a drain on individuals. We are still the only country in the world, in the developed world, that does not guarantee insurance coverage to all of its citizens. We are the only country in the world that says to millions of people, if you get sick, you may have to decide whether to feed your family, whether to pay your mortgage, or to pay your doctor bills. So we all know why we're here. We all know what the problems are, but what do we do about it? And that's what I'm hoping we can talk about a little bit today. We have a very distinguished panel of guests, starting with Representative Diana DeGette. And we try to get her name right. Not everybody does. She hails from the great state of Colorado. She has a long history of working on health care issues, starting with the state children's health insurance program, which was one of the first issues she dealt with when she arrived in Congress. She is now the vice chairman of the House Energy and Commerce Committee, which is one of the three committees in the House writing health care legislation. She's also the chief deputy whip of the Democratic Party in the House. Interestingly enough, she is very familiar with the Aspen Institute because she worked here in the summers as a law student. Yep. So afterwards, if you don't know where to go, just come up to her. She can give you directions, where to get the best food, and all of that. We are also joined on the far side here by Jason Grumet. Jason is the founder of what is now known as the Bipartisan Policy Center, which several weeks ago released a very important, not, I think, fully appreciated, but perhaps we can change that today.
Bipartisanship never is.
Vision for what health care reform could look like. Jason's great claim to fame in this debate is that he really doesn't know that much about health care policy. His specialty is environmental policy, but like a lot of people in Washington, he's been forced to learn about health care because if you want to work in public policy these days, health care affects everything. Sitting next to Jason is Douglas Holtz-Eakin, a very distinguished economist who ran the Congressional Budget Office, was chairman of the Council of Economic Advisors, and was the chief economics advisor to John McCain during the presidential campaign. And I can tell you, having reported on the presidential campaign, that there is no more difficult job than trying to be a policy expert in a presidential campaign. Because you are surrounded by people who want to make good sound bites, who want the poll numbers to be good, and you're sitting there, the lonely voice in the room, saying, you can't really do that. You can't really say that. And as somebody who certainly wrote things that were critical of the McCain campaign from time to time, I will tell you, I don't think this is a secret, that it was widely understood that Doug was one of the white hats in the room, trying to make the case for good substantive policy, good policy choices, and good, honest statements. So it's a pleasure to have him here.
Thank you.
And immediately to my right, we have Len Nichols, another distinguished economist who has done a little bit of everything. He's a veteran of the Clinton healthcare wars. And not only did he live to tell about it, but he's still working on healthcare. He may be more foolish than I am. Today, he is at the New America Foundation. And one of the things that's interesting about Len is that Len was on track at one point in his life to become a minister, perhaps, and is fond of quoting the scripture in his talks. I know Len pretty well. I actually think it's easier to refer to him by some old Yiddish terms that I know. Len is very much a matchmaker between different people who are interested in healthcare. And he knows everybody. Everybody talks to Len, and Len talks to everybody. So when people say, who is Len Nichols? I say, well, he's a Yenta.
Thank you.
Which I mean that as a compliment. I thought I'd start today by, like I said, we want to talk about how to solve this problem. And I think the guiding point for our discussion hopefully will be what is the common vision among this spectrum we have here for healthcare reform? And not just is there a common vision and what that common vision is, but is that common vision necessarily the best vision? Is it a given that something that we could all agree upon is how we should proceed? Or is it possible that what some of us think or what others think is better than the group as a whole? In other words, is bipartisanship the way to go, or do we want a more bipartisan bill? Is something, the least common denominator, always the best policy? And I thought I'd start with the congresswoman who is fresh from Washington. Maybe tell us a little bit about what is your idea of reform? What are the central elements that reform ought to have in order to be worthwhile?
Thank you, Jonathan. And I did bring the bill with me, but I didn't bring it up here because it's about this thick, and that would take more than 5 minutes. Anyone who wants a restaurant recommendation, remember, it was about 30 years ago that I was here, so that in mind. I thought what I would do, I'm going to talk to you about some of the key components that I think that we need to have in the legislation. I just want to put a little bit finer point on what Jonathan said about the urgency for health care reform in this country. You've all heard some of the numbers. 47 million Americans don't have health insurance. 9 million of them are children. And health care costs are now the leading cause of personal bankruptcy in this country. And unfortunately, despite this great cost, we're spending $2 trillion a year, which is twice as much per person than any other industrialized country, but our outcomes are abysmal. Women's health is 24th in the world. Infant mortality is 29th in the world. And life expectancy is 31st in the world in the United States. Overall, the United States healthcare outcomes are 37th, which is below the Dominican Republic and Costa Rica and just above Slovenia. And I just don't think that's where we want to be. That's my sense. And the Council of Economic, so people say to me and to the legislators all the time, how can we do healthcare reform in this economy? And what I always say is we can't not do healthcare reform because we can't revive our economy. You hear the president say this all the time. The Council on Economic Advisors just came out with a report about what's going to happen if this trend continues in the future. We're going to have if we slow annual growth of healthcare costs by 1.5%, then we can begin to stabilize this. But right now, the gross domestic product is going to be completely sucked up with healthcare costs and all of the non-discretionary spending, and most of the discretionary spending is going to be taken over with this. Healthcare costs are going to be 18%, or are going to be 34% of the GDP by 2040, and we can't succeed and compete in this new century economy if we don't do something. So what are we going to do about it? everybody's heard, and I know our distinguished panel today is going to talk a lot about the Senate plan or plans. But the House, Henry Waxman was the one who told me when I arrived in Congress, we do have two bodies in the Congress, the Senate and the House, and we have had a really successful tri-committee process working. Energy and Commerce, which is my committee, has the primary jurisdiction over health care reform, the policy aspects, Ways and Means, and then Education and Labor. And an extraordinary, talk about bipartisanship, let's talk about, tri-committeeship, because the fact that we've been able to get our three committees together to write a single bill is unprecedented in my 13 years in Congress. The Senate, they're still working on a product, but as you saw in the press, they were set back when the CBO scored the Senate bill at a cost of $1 trillion. But what was even worse, I think, it only insured 16 million people of the 47 million people who don't have health insurance. And so they're kind of retrenching and trying to figure out what to do. In the meantime, the House came up with our discussion draft about a week ago. We're still trying to get it scored, but I think the general consensus is that it's going to come in at a much lower cost and cover many more people. And so some of the aspects that we have in our bill, I think, can be used. Maybe if the Senate would read it, it would be good. But also as sort of a foundation for what we really need to do to have a successful health care bill that's going to cover everybody and that's going to save us money in the long run. First of all, we've got to cover every American. And especially, one of the aspects I was able to get included in this discussion draft is automatic enrollment of children in their first year of life, so that they automatically have a medical home. Everybody knows how important it is to cover everybody, and whatever plan we do has got to cover everybody. Otherwise, you won't get the health care benefits or the cost savings. Secondly, we've got to get cost containment by rethinking the way that we compensate doctors, and we've seen this in the Medicare program in particular. Thirdly, I think we need to rethink the Medicare prescription drug compensation, and in fact, the pharmaceutical companies and the White House have met and begun discussions in this direction. Fourth, and again, we've already started on this with the recent stimulus bill that we passed, we need to aggressively pursue health information technology. Not only will this save costs in the system, but it will dramatically improve patient outcomes. Fifth, we need to take a hard look at Medicare Advantage programs to see if we can get cost savings through those programs, but also to see if we can get patient improvements. We need to build quality measures into our plan. This is something that Senator Sheldon Whitehouse and I have been working a lot on. In Massachusetts, when they passed their plan, they didn't have any quality measures built in. And I'll talk about the cost containment of the public plan in a minute. But what happened was, the good news is they covered everybody in Massachusetts. The bad news is costs did not go down and patient quality has not yet improved. So quality measures go hand in hand with any kind of comprehensive national health care plan. Seventh, we need to reward plans for efficiency. We need to build on prevention and other kinds of efficiencies in the system. Eighth, we need to realize that this is a shared responsibility between patients, their healthcare providers, and their insurance providers, whoever that may be. And finally, and I saved this till last, I don't feel we can abandon a public option. The debate in the press lately has been, are we going to have a connector system like Massachusetts that will be insurance plans competing with each other, or will we also add a public option in here? You can structure a public option in many, many ways. And the way we structure it in our House draft, we make it comply with all of the same requirements that we make private insurance plans comply with. And we make it compete in price with the other plans. But if we don't have a public plan, it's difficult for me to see how we can get true competition and cost containment in our system. I think it's unfortunate that the press debates have now become about public plan versus versus no public plan, because I think the debates in the press right now should be, okay, how are we going to make this the most efficient system that we can with the best possible patient outcomes, and how are we going to pay for it? I think that in the end, that's going to be the biggest fight that we're going to have, because with the economy the way we are, the fiscal budget hawks, and I consider myself among that group, are going to be saying we need to be able to pay for this plan. And some of the ways we're going to have to pay for it are going to be very, very painful, and I think that's going to cause a big debate. With that, I think that's a good start on my part. Thanks,
That's
Jonathan.
a good overview. Thank you. Jason, your organization came out with, as I mentioned, a framework, and it was endorsed by some very prominent former senators. And I understand, I mean, this was not just they kind of came in at the last minute and decided to have a press conference. This was Senators Baker, Dole, Daschle, and then, of course, Senator Mitchell has gone off to serve in the administration. But they were playing like they were back in Congress, trying to come out with a vision that they could come together. Just quickly, give me the sort of 2 or 3 elements of how is it different from what the Congresswoman just described in terms of what does that plan look like?
Sure. Well, so let me just say good morning and a few words about our Bipartisan Policy Center. I don't believe much in objectivity, but I think transparency is an important starting point for most public discussions. So as Jonathan said, this organization was founded with 4 former Senate Majority Leaders, Howard Baker, Tom Daschle, Bob Dole, and George Mitchell. And when they came together, they decided that they personally wanted to focus on health care. We work on a variety of different issues, from energy to homeland security to transportation, but this was the piece that they really wanted to roll up their sleeves on. And for the last 18 months, they have been coming together, having detailed, generally constructive, but tough discussions. I pretend no depth of expertise in health care, but I'm here channeling a number of people who do, because in addition to the 4 senators, this project was directed by Dr. Mark McClellan and Chris Jennings, who are kind of the bipartisan, id in the healthcare policy wonk community, in addition, of course, to Len, the Yenta. And let me just say a few words about our point of entry, because when I tell people I run something called the Bipartisan Policy Center, they usually say something like, good luck with that, recognizing that it's not exactly the place where most people are hanging out these days, and that's, of course, exactly the point. There's tremendous institutional infrastructure to support folks on the left. There's tremendous institutional infrastructure to support folks on the right. But when you talk about having a highest common denominator, a principled compromise where folks actually put themselves on the line, there's really nobody there to help them up. And so that's really what we've been trying to do in this process. And as Jonathan said, this was a little more realistic than we actually even had imagined, because the 4 majority leaders are used to being able to kind of cut deals the night before the big rollout, which when you are actually running the government, you can get away with. We were editing our report until the night before our press conference. We decided to basically play a game of institutional chicken with ourselves, invited Jonathan and a couple of hundred of our most favorite friends to come to a big room in Union Station before we had a deal. And we tried to remind the former majority leaders that when you're in the shadow government, you have to do things like rent a room and invite people to come. You can't just kind of wander in, with your hair mussed up and say, here it is. But we managed, in fact, to get the gang together. And I'll just give you kind of the 3 kind of overarching kind of themes of this compromise. I will note that what we tend to do is put deals together before everyone else is ready to go there, which tends to piss a lot of people off, because the process has a lot of energy to the fight. And one of the ways that we think you can accelerate moving things forward is if, in fact, you kind of point to that direction. I also think it's important that, we don't want just people to get along. But this is not bipartisanship just for fun, because we think it would be a nice world if everybody kind of hugged it out more often. We have a 2-party system. We're not the post-partisan or the meta-partisan system. We are the Bipartisan Policy Center, but that's because when it comes to issues like health care, issues like climate change, things that are going to be truly transformative for our society and economy, durable solutions require more than 51% of the country to be on board. If you look back at Social Security compromise in 1983, we had 88 votes in the U.S. Senate. You look at welfare reform, we had 74 votes in the U.S. Senate. If we're going to have the kind of durable solution we need here, we're going to have more than just one party owning the credit and handling the blame. Because this is going to be an ugly this is a sixth of our economy. The transition from where we are to where we need to go is not going to be a smooth one. Australia has passed and rescinded universal health coverage. And that's not an experience that we're going to be able to survive here. So it's our view that, in fact, there is a highest common denominator. I think elections do matter. But if we're going to have the kind of change that's actually going to be durable and sustainable, we think there has to be that kind of principled compromise. I will note that no one likes anybody else's compromise. I will also note that ours is aging a little better than fish. As Jonathan pointed out, when we first came out with it, there was a lot of criticism, because it's just that. it's a compromise. And so here are kind of the overarching ideas. You have to marry universal coverage with significant reform. And they have to happen together. If you simply expand coverage, but don't reform the way in which we actually provide health care, the costs are going to be absolutely out of control. If you try to reform the system, but don't bring everybody in, it simply doesn't work. The healthcare system we have right now is defined by insurance companies trying to avoid sick people. That's the deal. I mean, that's how they make money. That's how it works. So if you allow the 45 million folks just to kind of slide under the radar, you wind up basically having each of the rest of us paying about $1,000 a year to subsidize those uninsured folks. And so we always talk about kind of we're rationing healthcare right now. We're just not doing it with any finesse, grace, or purpose. And so you have to essentially bring everybody into the tent and then dramatically reform the incentives so that we're not paying people for the volume of health care that they provide, but actually for the value and the quality. And you have to come up with a system of providing incentives and shared savings so that when doctors and hospitals actually make people healthier cheaper, they make some money off of that. There also has to be a significant focus on prevention. This is something that Congresswoman DeGette, I don't forget, it's DeGette, has been really leading on. But one of the things that our proposal calls for is a $50 billion focus on wellness and prevention to try to deal with those chronic diseases before they, of course, become 75% of our overall healthcare costs. To deal with the ideological challenges, we've really focused on shared responsibility at two levels. There has to be shared responsibility between individuals and employers. So we call for a mandate, both on all of us to actually have to have health insurance with fees if you don't, and a mandate on employers to actually provide health insurance for all of their employees or to pay a fee. So it is combining two things that both, the Democrats tend to be more comfortable with the employer mandate, the Republicans tend to be more comfortable with the individual mandate, and we're basically saying everybody's in. The second place where there's going to have to be shared responsibility is between the feds and the states. And the emotion in healthcare is always the kind of big government getting in your way. What we have proposed is that the federal government is going to have to set some basic standards. Everyone has to be able to have access to insurance. Health insurance companies can no longer rate their premiums based on whether you're healthy or sick. Everybody has to have the opportunity to keep their health insurance throughout the course of their lives. But ultimately, it's going to be incumbent upon the states, not the federal government, to enforce these new standards. And we'll talk a little bit about the public option, which has become, of course, one of the high points of this discussion. And then finally, you got to pay for it. Because, that stimulus was a lot of fun. I worked on the presidential transition. Spending $1 trillion during a transition is a neat experience. I wouldn't suggest we do it often. But there is no more money. Everything going forward is going to absolutely have to be paid for. We have proposed a $1.2 trillion plan over 10 years, which sounds like a lot of money. It is a lot of money. But over those 10 years, the country is going to be spending upwards of $35 trillion on health care. So put it in perspective. And we propose to pay for it. We propose to pay for it by achieving about $500 billion of savings by restructuring payments and dealing with the Medicare Advantage program, which is not providing that much of an advantage, at least fiscally. We propose to raise new revenue. One of the more controversial aspects of our proposal is we are proposing to tax the health care benefits that members get from their employers, not at zero, but at the level that members of Congress get. And I patted Doug because this was a debate between President Obama and Senator McCain during the campaign, where Senator McCain called for actually taxing health benefits, not subsidizing them. And what the three senators who came together in our program proposed is to start to tax them at the rate above which members of Congress get their free insurance, which is about $12,000 a year. So that if you're really looking to have the kind of I guess you can't really say Cadillac anymore, because if you're really looking to have the Prius. Thank you, Congresswoman.
Hey, some of us live in Michigan.
If you're looking to have the Prius plan, that's all good. And the public's going to subsidize that up to a point. But if you really want to go that extra mile, at some point, we have to start thinking about the 45 million people who have nothing, not the people who want to have everything. And then finally, I'll just say a word on the public plan, because this has become the political mythology in the debate right now. In other words, one of the things that's remarkable, and Jonathan's written about this, is everyone's playing pretty nice. The stakes are big. People are walking around with very, very big hammers, but they're not whomping each other over the head with them right now. The key interest groups that scuttled the Hillary healthcare effort 15 years ago are circling each other but talking nice. Members of Congress are actually having pretty constructive discussions. The one place where things start to veer off the rails, and where you can see the whole thing exploding, is over the kind of the ideological mythology of, should the government come run health care? If we can keep the debate away from that question, we can provide universal health care for this country. If we get trapped in that discussion about whether government should be between you and your doctor, this is going to blow up again. And the idea of a national public option is the place where those politics become most heated. So what we have proposed is that states and regions be authorized and encouraged to set up their own regional public insurance options, that the federal government provide technical assistance and financial assistance to get those programs going, and that if after 5 years it turns out that we are not, in fact, succeeding in providing the kind of health care at the cost and value that we believe, then the federal government should come back in and propose a federal public plan. But trying to basically say this is a very important issue, but it's not the only important issue, and try to avoid having this become the fuse that blows up the healthcare powder keg. Thanks.
I'm going to go over to Doug now, and let's not talk about the public option just yet, because we will get to that. I did see you nodding in a few places, but I'm going to give you that hammer.
But not falling asleep. So.
That's good. Well, that's good. If you're not falling, if it's healthcare and you're not falling asleep, you've won half the battle. Of this vision, that sort of, I mean, these two people are not that far apart. What can you buy into? And let's not talk about the public. I know the public plan is a point of difference.
So first, in terms of the context, and I think this is actually very important. Number one, we have an economic need for healthcare reform. I think the Congressman said it exactly right. The healthcare sector is about 1/6 of our economy. It underperforms. If you care at all about growth and prosperity, having an anchor, which is 1/6 of your economy, is not exactly a route to better success. So there's an imperative here to improve the performance in this sector of the economy. There's also a clear political imperative to get something done. I want to thank Jonathan for his kind words about the campaign. People often ask me, sort of, what do economists do in Washington? And by and large, what you do is you kill bad ideas. And I can assure you there's no more fertile environment for bad ideas than a presidential campaign. To have someone recognize that I once aspired to be 6'4" and have a full head of hair, and this is what happens, it was nice. But, one of the remarkable things about the campaign that people didn't, I think, fully appreciate is every Republican candidate had to have a health care reform plan to get the nomination in the primary. This used to be a Democratic issue. I mean, honest, the Democrats talked about health care, the Republicans didn't. The American people care about this. And so this represents a very important moment. And I have always thought that there was a great opportunity for a bipartisan reform. I think Jason's got it exactly right. Bipartisan reforms are better. They are more durable. And we simply cannot give up another 15 years because we couldn't get it together and figure out what the principal compromise is. So where can you go, and what pieces can Republicans and Democrats get together to support? Number one, I don't think there's any big partisan problem with delivery system reforms. The fundamental problem in the United States is that healthcare spending per person has grown 2.5 percentage points faster every year for 30 years than has income per capita. So if you're running a horse race between what you spend and what you have to spend, and you're losing by 2.5 percentage points every year, you're in trouble. And so we need to radically alter the incentives to deliver care in a way that is not strictly based on the more you do, the more you make. We don't care about the outcomes. This is the latest, most expensive gadget. We're going to use it. I mean, that kind of medicine is at the heart of what we have to do. That's not a partisan issue. Bipartisan, I think everyone gets that. The hard part about that is it's about doctors and it's about hospitals. And I defy you to find me a congressional district that doesn't have a doctors and hospitals. So that's going to be a very hard thing for this Congress to do regardless of party. It is hard to change that much of American life. But it's something that needs to happen, and both sides are on it. The harder part are coverage expansions and paying for it. The coverage expansions, if you just write the checks and don't do the delivery system reforms, you're in big trouble. We are already in, and this is the technical term, big trouble budgetarily. I mean, the outlook for the U.S. federal budget is nothing short of disastrous. And for us to send the message that we're not going to pay for this and let the Chinese finance our health care reform would be a terrible message to send, because they'll probably yank back the financing before we get the job done. So this has to be paid for, and your appetite to pay for it will dictate how aggressively you can do the coverage expansions. And that will be where the rubber meets the road in the Congress. There's no question about that. And I don't think anyone should have any illusions that you couldn't do better in getting people covered because we have 50 different state insurance markets in the United States, and you'd be hard-pressed to make them the models of perfect competition. I mean, economists love for high-quality products to be delivered to consumers at a low price. That is not what our health insurance markets are delivering. So we have some insurance market reform to do. We have some assistance for poor and high-cost patients we have to deliver, and we have to make sure the whole thing adds up. So that'll be the hard part.
Well, I want to turn you. I mean, you could do a course of Kumbaya here. Everybody's on the same page. Obviously, everyone's not on the same page, and not totally. We haven't talked about the public plan yet. From your vision, I mean, what do you think the central elements of reform are? And we heard about what you thought were the big. Where do you think the big dividing points are?
Well, first let me say what I think we've got to do, and then we can talk about what's dividing. And let me begin, if I could, by saying just a word about New America, because we are not exactly a household name. We're in the spirit of Jason's group. We were created about 10 years ago by a couple smart people and a couple rich people who realized Washington was stuck in a kind of gridlock that was serving fundraising for each party, but not solving any problems. And let me emphasize, we're totally in favor of bipartisan solutions, but that means solutions. That doesn't mean just because you can get votes for a certain thing. It means solve the problem. Now, it's true, it's hard, it's pushing a square boulder up a hill, because you know quite well, you can make a very fine living, have a long, distinguished career in Washington, pretending to believe things that are not true. You can make a very fine living, have a long, distinguished career demanding things that cannot be. And my self-appointed task is to piss them both off every day, but to keep them talking to each other. Because it is in talking to each other you have a chance. So what are the elements of really solving this problem on a bipartisan basis? Number one, you got to cover all Americans. That fundamentally means you got to change a business model that is, as Jason said, about risk selection. You have to end the ability to separate the sick from the healthy. You have to end it. It has to end. The second thing we got to do is make our system sustainable, as everyone has said. And indeed, I've been very heartened by the way it's in the House bill. It's all over. This is not some grand conspiracy. This is a broad view. We have got to make our system sustainable. That means ending fee-for-service. Not tomorrow, but sometime in the near future, sometime in the next 5 to 7 years. That's all about getting the incentives right. I think one of the big questions is, I mean, Doug's right, a lot of Republicans get this. The reason we've had so much productive bipartisan conversation off the airwaves, but it's going on behind closed doors, is because of this consensus about the need to do this. The problem, my gentle friends, is those who feel they can still demagogue and win, because they're going to say you're rationing grandma to pay for Pedro, and we got to deal with that reality. So we got to stop risk selection. We got to end fee-for-service medicine. We got to acknowledge we got to pay for it. We also have to acknowledge, let's all take a deep breath. We can afford this. It is true the Chinese have loaned us a lot of money. It is also true that when you borrow a little bit, you got a creditor. When you borrow a lot, you got a partner. They have a profound interest in making sure our economy does well, because who you think is going to buy their stuff? More importantly, who do they think is going to buy their stuff? So the notion they're going to somehow pull it out if we go over 1 point is just, a little bit Cassandra. I will also say, and Doug is not among these, among those who say we can't afford it, the loudest are those who said just a couple of years ago, we can't afford to cover children. There were 17 Republican votes for the House version of the S-chip bill, which Congresswoman DeGette helped happen. 17 Republicans voted. That's 68 votes. She had veto proof in the Senate. Yet, some will say we can't afford to cover children. Well, let me remind you of this. Even if you go the 1.6 trillion, which was actually the sticker shock that got the press all excited in Congress a couple weeks ago, the 1.6 trillion rumored out of the Senate finance bill, which none of us have seen, but we all have smelled, okay? That 1.6 trillion over 10 years is 0.8% of GDP. 0.8% of GDP. Now, I'm for paying for it. I'm going to tell you how in about 2 minutes. But I will tell you, if we're not willing to spend 0.8% of GDP to cover all Americans and make our system sustainable for all of us, then we are penny wise and pound foolish in the extreme. Now, some of us are, but luckily, a lot of leaders are not. Let me also remind you, we've faced economic crises before. You know, we're talking about 13% of GDP this year as a deficit. In 1943, let me remind you, our deficit was 31% of GDP. And I would submit to you, the existential crisis we faced in World War II was about saving civilization. I submit to you, the stimulus money, the bailout, all that stuff, trying to prop up Michigan, is all about saving civilization as we know it. These are very important, serious fiscal stimuli we absolutely positively have to undertake. We quibble about details. No economist quibbles that we need a fiscal stimulus. And my point is, 31% of GDP was a deficit in 43. The debt to GDP ratio went from 50 to 120% of GDP in 5 years. And somehow we managed to keep the third grade and hospitals open. And we won the war that saved civilization. Today, we're talking about going from 50 to 70% debt to GDP ratio. I'm sorry, 70 to 90% GDP, which is right in the middle where we were in World War II. And we're talking about doing it in a way that we're ultimately going to pay for this health reform. So fundamentally, I think the extreme rhetoric about, oh my God, we got to go back and hunker down in some kind of cave. People are not paying attention to the realities. What we have done before in this nation, that is, we borrow when we have to, and we pay it off over time. That's what good families and good societies do with good leadership. So how are we going to pay for this? There are, in my view, three and only three buckets. The first bucket is some kind of tax increase. That's not one of the most popular buckets. It's a bucket that basically says we either increase income tax rates or somehow reduce deductions for high-income people if the president gets his way. Or you could imagine new taxes on things like high fructose corn syrup. Who knew Coca-Cola was bad? I grew up in the rural South. I've been drinking Coke, 5 times a day for, 55 years. My grandfather always had a case of it cold just in case. And turns out, well, I've switched to Coke Zero, and it turns out you can indeed tax that stuff. But that's one bucket. Probably not going to go in there too deep. Second bucket, the current tax exclusion for employer contributions. That is a way today we essentially subsidize Bill Gates, but we don't subsidize the people who pick up the garbage in our offices every night because they work for firms that don't offer. And they get no subsidy at all. And that subsidy is proportional to your income tax rate, so it's absolutely regressive. And it's, by the way, leaving approximately $200 billion on the table every year. The third bucket, and this is the bucket where I think, in fact, we need to and can engender the most bipartisan support, is what I will call delivery system reform. You could also call it efficiencies in Medicare. What I'm really talking about is payment reform. And I will say, if we do this right, we have the potential not only to partially pay for coverage expansion, but more importantly, actually, to begin to move the battleship of our fiscal imbalances. We're not going to do this unless we do it with incentives. And we're not going to do incentive realignment unless we do coverage. Let me give you one little fact, and I'll quit. 2/3 of hospitals in this country right now lose money on Medicare. Now, I will point out that is not because Medicare underpays. It is because 2/3 of our hospitals, let's be frank, have not achieved the levels of efficiency we know they can. But let me tell you a secret. If you try to do payment reform, cost growth reduction, all that root canal stuff, without covering the uninsured, then 2/3 of hospital boards are going to come in little buses to the Congress and camp outside the Capitol, and they're going to say, you cannot do this to my community. Therefore, I don't want to make this up or make this too glib, but I will say, while Coverage is fundamentally a moral question. And I can quote Leviticus, the Quran, even the Book of Mormon, whatever you want. But I will tell you, it's also a bribe. It's a bribe necessary to buy time for our health system to become as efficient as we need it to be so that it can be there for us. We have a choice, sports fans. We can fail to do this. We've done it before. I've lived to see it. I've got scar tissue to prove it. But if we fail this time, here's what's going to happen. 4 or 5 years from now, some other brave politicians will come back and take it up. And they will be looking at the Medicare cost trajectory right in the eyes. And they will say, oh my God, we're going to have to put on price controls because it's the only thing we know that will work. And in the short run, I bet you even Doug will agree, price controls will hit any budget target you want. It'll screw up the system forever, but it will hit any budget target you want. And that's what we face. We face the choice of doing this together now in a bipartisan way, but solving the problem, or failing and getting price controls in 5 to 7 years. So that's what's at stake.
I want to go quickly to a couple more quick questions now, and I want to go right back to Doug. Len just gave what I think is very much what you often hear from the president, his rationale, which is, yes, the outlays may cost a lot of money for a while. We may be sending a lot of money out the door. But as long as we do that in a way that brings that spending, we pay for it within some window of time, it's worth doing because in the long run, we will save more money and, by the way, take care of this moral problem. Do you buy that argument?
So, in part. So let me just say very clearly what I think the budgetary constraints are and why they're important. I'm not worried about 13% of GDP this year. I'm worried about the fact that if you take the administration budget and price out where it takes us to a point 10 years out where we've doubled the debt to GDP ratio and it is rising. We are borrowing $1 trillion a year, and we're borrowing that $1 trillion a year because about $800 billion of it is interest on previous debt. And so we are under the current policy outlook, without doing health care reform, a slow-moving emerging markets crisis. We're just borrowing to pay off previous interest. And that's not a place the United States should go, period. And I don't view that as a big scientific dispute. So what do you do with health care reform? Well, you don't borrow it. I mean, you pay for it. I think Len's right about that. I mean, the numbers he said about spending the money, they're small fractions of our economy. That's all true. But you have to put together a sensible package of how you pay for it. So in those buckets, one of the buckets is delivery system reforms that address the thing I'm concerned about, the fact that a sixth of our economy spends a lot of money, we don't get high-quality outcomes, as Congressman said. I mean, that's all real. The problem is neither Len nor I nor anyone who wants to do this knows how fast we can get them done, how quickly they will generate better practice, how large the savings will ultimately be. And so you can't let those be the foundation of the budgetary architecture on which you build the coverage expansions because you might not get it. And that's a risk that we face and ought to be part of the discussion like this. Everything has risks. There's risk of not doing it. Len was very eloquent about that. But there's risks about how you do it as well. So when the president says, we got to go do this, and it's how we solve the long-run budget problem, yes, but let's get to the long run. Let's not do it, as, for example, in Massachusetts did, where you cover everybody in an instant, you don't have the cost containment, you don't have the other pieces, and you just have a big problem, and now you scare people further about the outlook for the U.S. federal budget. That would be damaging in international credit markets. That's my concern. It doesn't say you don't do it, but how you do it matters.
Congressman
I agree with that, Doug, but I've got to say that I keep hearing my buddies across the aisle talking about this, the budget implications, and we're all scratching our head because before 2000, of course, we were on the plus side of the ledger, and now we feel like we're trying to
rerun history.
But
we're at a place where we can't afford to do that.
But we're trying to dig ourselves out now, and part of what we have to let me finish.
Part
of what we have to do to dig ourselves out is to restructure our healthcare system because the trajectory is so bad. And so, as I said, and part of it is the new generation of members of Congress, like me, Democrats and Republicans do tend to be fiscal budget hawks, and we're trying to figure out how to do this and pay for it in the best way. And so some of the things I would imagine would fit in some of these buckets that I talked about. Health IT will save hundreds of billions of dollars once we get that fully implemented. But you have to make the upfront investment to do it. Issues like restructuring Medicare Advantage, which is wasting, again, billions and billions of dollars trying to give incentives to private health care plans to manage Medicare, which seemed like a good idea at the time. I supported it. But now it's just bleeding money that we don't need to bleed, and so on and so forth. But if as you suggest, the way we start is by looking at the insurance programs we have right now and just doing that without having some kind of a mandate to put every American into insurance, then you're going to be, I think you're going to be doing what they did in Massachusetts, which is perpetuating the same high-cost system. Part of the problem with the insurance markets, you can tell everybody to get insurance, but as you know, the insurance markets in this country have consolidated so much that in most markets in this country, there's really no competition. In Pueblo, Colorado, for example, there's one insurance company. I think they cover like 82% of the people in Pueblo. So you don't get the market benefits of competition, which would bring down premium costs. So I guess the problem I see, I am fully committed to paying for this, and I think there's many ways we need to do it. We may have to look at a tax on the insurance benefits for higher income beneficiaries and other things that are unpalatable. The last thing a politician wants to see is an increased tax. That is a bane to our existence. But it's like your mother taught you when you were doing your budget. You have to be able to pay for what you're spending, and we're committed to that. But we've got to do it in a way that's going to make sense from a structural standpoint.
So you want to
Let me just jump in on the delivery system piece because I think it's relevant. I would quibble with Doug on one point. My guess is we have a different time frame in mind. So I know it from CBO, 2008 to 2019, the debt to GDP is going from 70 to 90.
40 to 82.
It may go
40 to 82.
Well, okay, then we can quibble about the data later. But anyway, here's how we're going to solve this problem. Doug is right. I don't know how to do this. I know people who do. This is a group I pulled together called Health CEOs for Health Reform, and I got a few copies. I'll be glad to send you more. And what it is a group of people who run real health systems around this country, including Patty Gabot from Denver Health, including Nick Wolter from the Billings Clinic, which is Mayo West, including Gary Kaplan from Virginia Mason in Seattle. But even more interestingly, those are all integrated systems that are doing well. People who run hospital systems, big, heterogeneous, inefficient hospital systems like Ascension and Catholic Healthcare West, along with the drug company and some other insurers. And here's the bottom line. These guys are willing to say we have to end fee-for-service. They're willing to lay out all the payment reforms we all would agree and write down. And Doug's right, we don't know how much they'll quantify now, but here's the difference in them and the most of the world. They're willing to say in year 6, if we have not achieved the level of savings that we get to, that we want to get to, they're willing to take what we in Washington call a hammer or a trigger or a fail-safe. That is, cut, lower, absolutely reduce updates from the Medicare program in order to hit the targets you need. That kind of thing is scorable. Jason got his bipartisan group to support such a thing as well. As far as I know, we're the only creatures on the planet that have done this, and we both wear bulletproof vests every day.
Very lonely.
But the bottom line is, let me tell you what, it's really about what real people in the real system know is feasible, and it's about making clear we are going to change incentives, and it's making clear we're going to reward you for doing the right stuff. And it's making clear you are not going to be able to prosper doing the kind of extra stuff that a lot of people do just for fun. You're not going to be able to prosper that way very much longer. And those kinds of signals need to be extremely clear. If we can get the politicians to do that, and Congressman DeGette is one of the bravest. You actually mentioned the T word here. I'm impressed. Because that's what it's going to take. All choices are painful. All of them are going to have to dip into these buckets. But if we don't do it, the consequences are worse.
And John, I'll only just kind of reinforce that, which is that none of us really know how well this is going to work. And I think we have to find a way to legislate something that captures kind of aspiration and discipline. And the way you do that is you put all the good stuff in place, and then you have a verify. The word trust me just doesn't get it done in the U.S. Congress when you're talking about trillions of dollars with ideological differences. And so it's not impossible or even that complicated to put together a set of systems. What we propose is a series of benefits that Tom Daschle felt were not aspirational enough. And so what we agreed was if, in fact, we don't save as much money as we think we should, well, then these kinds of automatic ratchets are going to have to take effect. But wait, what if we save more money? What if this, computerizing health records actually turns out to be a really, really great thing? Well, then we're going to plus up the benefits. So in other words, we have to recognize that this is going to be an iterative process over time. There are going to have to be kind of, chutes and ladders. And if you try to design legislation that doesn't require the people across the aisle to trust you, you can usually pass it. When it does require those kind of catch-me games, people's heads tend to hit the floor, and we wind up yelling at each other a lot.
I do want to give the audience time for questions. I want to do 2 quick passes on 2 specific issues. Let's talk about the public plan. Everybody talks about the public plan. The generic case for the public plan, Doug, is that why not offer people the opportunity? It's a way of guaranteeing security to everybody because the government will have control of it. It'll make sure they won't play games and keep people out. It can discipline the private sector. There are ways to safeguard it so it doesn't simply underprice every private plan and drive everyone out of the market. It's competition. It's choice. You're a conservative. What's wrong with this argument?
Okay, so
Against choice, Doug.
Why are you against choice?
The policy objection to the public plan is it doesn't solve any of the problems that our system has. One version of the public option is you basically have a company that pays Medicare rates plus 5 or maybe 10%. But Medicare payment systems are the problem, and propagating that throughout private medicine and health insurance as well is a step in the wrong direction. So that model should go. Another model of the public option is one where they look just like a private insurance company, and literally you might even say they're going to be just like a private insurance company. They're going to pay local taxes, state taxes. They're going to be configured that way if necessary, or they'll be a not-for-profit. They'll be just like a Blue, and then you have that, and you somehow guarantee that this wholly owned subsidiary of the U.S. Congress is going to face bankruptcy risk, which is something that's very hard to do. So you let it compete on a level playing field. Well, then you need good competition, but wait, we don't have good competition, so we have to fix these insurance markets to make sure we have good competition, because we don't right now. So it's not the public option, it's insurance markets suck. That's true. So the public option doesn't solve any of your problems. It's something different. It's off the problems from a policy point of view. Then there's some political problems, and if you want to get a bipartisan bill, I mean, I'm not your enemy. I campaigned for 2 years with a reform that raised taxes on some people, and I believe this is all good stuff. But there are Republicans out there who are very, very nervous about this, and you have to recognize this as their fear. If it gets in the way of cutting the bipartisan deal and it doesn't solve a policy problem, why do it?
Len?
Well, what I would say Doug is missing is there are 2 pieces of the policy problem it actually does solve. One is, it was news to me, but there are people in our nation who truly do not trust private insurance at the level where they see the Blues, they see Kaiser, they see WellPoint, they see them all as the same. And they see them all doing things every day in the news that basically, from their point of view, deny people benefits that they thought they had paid for. And they see, and that trust problem is real. There's a symmetric trust problem. There are people who don't trust government, and I agree completely. We got to find a way to write a contract to make this work. So that's why I proposed, as you know, a form that would pay market rates, so we wouldn't have this and get a 2/3 rule and can't change market rates, whatever. But the third piece of the motivation behind the public plan is actually to serve as a benchmark in markets where competition is not great now. It's not that many markets, actually. I would agree with that, Doug. But here's the deal. There are markets out there in this country where certain insurers have market shares right now in the individual and small group market well above 50%. We're all for making the rules different and making an exchange be the place where individuals who don't have good large group options get to go. But who's going to oppose that the most? It's going to be the very insurers who now are making, let's be blunt, technical term, juicy margins off the current situation. We're going to put them in a world where they're going to make lower margins. If they are faced with a world where there's very little competition at the local level where they are, and you don't have some kind of public plan as a competing device, at least as a fallback, then what you've got is a situation where they're going to bid high, blame it all on the government and all those regulations, and try to drive the people against reform. Whereas if you have a credible threat of an actuarially fair bid that will compete on a level playing field, then they can't bid high, and you don't need all this stuff. So there are probably, I would say, 15 states where that's true. So that's why I like Jason's twist on this whole thing. Give the states the choice, but you got to give them a power to make it a real threat.
I actually, the thing I've been advocating is very much in the spirit of what
Yes.
Jason said. I mean, state-based approaches make a lot of sense. Our states are very different in their demography. They're very different in their rates of uninsurance. They have very, very different rates of Medicaid, both eligibility and take-up. And many states, Massachusetts, a blue state, Utah, a red state, have done comprehensive health care reforms in a bipartisan way. And I think we ought to respect those efforts, respect the differences of the states, and really put them at the centerpiece of this effort. There's a lot to be said for that. If the fallback turns out to be what's necessary for political trust and for economic leverage, I understand that argument too.
Okay.
Did you want to?
Let me just say, early on I didn't co-sponsor any of the bills because I think there's good ideas in all of the bills. And certainly for someone like me, I don't necessarily object to state-based insurance as part of a bigger plan. But there are a couple of concerns with that we would need to talk about. The first one is, could states actually afford to mount a sort of public plan option? We're having discussions about whether we can afford whether a national public plan could afford, if they weren't linked somehow to Medicare and to the rates and to the provider networks and so on. So that's the first question that we would have to answer. The second question that we would have to answer is, what do we do about the movement of people from state to state, and what kind of national provisions and requirements would you have to put on that? And if you're being so restrictive on that, does that then turn into an extremely inefficient? So I think these are all issues. I think these are all issues that we would need to discuss. And frankly, I think the reason many of the Republicans initially developed this visceral distrust of the idea of a public plan is because they thought that it was an insidious plot on the part of the Democratic leadership to move us into a single-payer system, and they didn't want to go there. And I can understand that impulse, but as Nancy Ann DeParle, who's the White House healthcare guru, said to me, there's a lot of different ways you can structure a public plan. And my main concern, and I think the leadership's main concern, is that this public plan be structured in a way that it actually incentivizes competition, because that's what's going to drive down the rates for people.
I don't want to say much because I think they've all done a better job promoting our study than I could. But I would note that this is the very conversation. I mean, Senators Dole and Baker spent a lot of time talking to their colleagues and basically got that back, that this is just the slippery slope to government-run health care. And when Baker and Dole say, look, folks, we cannot be the party to know. We have got to be at this table. The public plan was the easy bush that people slid behind.
Sadly, they're no longer in Congress.
No, but they're, I think the fact that they're getting a realistic sounding, for better and worse. But you raised the exact right points, which is small states are probably not going to have the resources to do this alone. And so to make the Federalist hand it to the states a meaningful and sincere proposal, you have to provide real technical assistance, real funding. You have to support states to work together in regions. And you have to make sure, and this is something I think Len has really been very strong in, you have to make sure that the underlying exchanges work and are real. I mean, if the underlying exchanges, and this is all fancy talk, but basically, if it's not possible to go and look at all the different insurance options and have a minimum credible federal offering so that they all have to be at least this good, if that's not there, then none of the rest of this is going to function. And so I think making sure that you focus on that first and the public option as a secondary issue, I think, is what's going to get us done.
Okay. Doug's going to say one more thing, but I'll just say when he's done, we'll take questions. So if you have questions and want to line up at the microphones on the side, that way when he's done, we can go right to the questions.
So since it's my job in this forum to channel Republicans, whether they be from the whack job branch or not, let me just say another thing that's this is just hard, and it's got to be on the table because it comes down to this whole issue of universal coverage, people walking into emergency rooms uncovered, hospitals needing payments to compensate them, and it has to do with covering those here illegally. There are 12 million or so, 15, take your guess, who are uninsured, who are not citizens or legally permanent residents. And I have enough scars from immigration reform debates to suggest that doing immigration reform and path to being legal along with healthcare reform is really, really hard. And so I don't have a good answer to this one. But for those who say you got to get everybody in, and if you don't get everybody in, it's not going to work, you've got to put up a red flag and say you need an answer to this.
Yes, you're right.
That's right. We're going to go up there, start there.
I'd like your opinion on employer-mandated health insurance. Employers got into that as artificial thing because of what price controls years ago. I run a small business, and I have a hard enough time understanding the business that I think I know something about. Certainly don't know anything about health insurance. So I think that it's a mistake to mandate employer coverage.
I would agree. It's a mistake. However, elections matter. It's going to be hard to avoid. What we're all trying to do is figure out a way, and I'm pretty sure Congressman DeGette's right here with us, trying to figure out a way to make sure the burden on small business is tolerable. And that may very well include, in fact, in my opinion, if I won't speak for her now, I'll say it should be an exemption for certain small and low-wage firms, no doubt about it. In my view, it would be better if we had no employer mandate at all, but because it basically just ends up being a tax on low-wage labor, and that's not what we want to do. But I would say the concept of shared responsibility has sufficient salience that it's going to be probably impossible not to have some kind of arrangement. What we're trying to do is mitigate it on small business and give small business far better options.
My comment was that you're asking people who know nothing at all about the industry to provide it.
Well,
it's not a problem of sharing the cost. It's a problem of knowing what the hell we're talking about.
Go ahead.
Yeah, except for if we really put together these exchanges as they have in Massachusetts, then it will be much simpler for employees and their bosses to figure out how these things work. The concept is that there will be an exchange where people can go online. They can know that they're going to have minimum benefits. They're going to know that they're not going to get turned down for a pre-existing condition, and so on and so forth. And what they're really shopping for is a basic package and then some more bells and whistles, which will cost more money. But it actually simplifies the whole system, not just for the employees, but for employers at all levels. We also want to try to encourage employers who are currently offering insurance to keep their people in those insurance plans, because that's the last thing we want to see is that drift out of the current people who, it's interesting when you poll Americans, the vast majority like their insurance plans and they should be able to keep them.
Go to this side.
In her opening comments, the Congresswoman gave us some shocking statistics as to the quality of medicine in this country. Now we've spent an hour and a half talking about universal health care without ever mentioning a single thing about quality. Is that appropriate?
Jason, you want to talk about?
I think it's a very important point. We have the best healthcare system in the world, except for access, quality, and cost. And there is this American exceptionalism that makes it hard for us to grapple with these statistics. I think we're not talking about it in some ways because we're all agreeing about it so much. The fundamental idea behind what we're all saying is that we have to reorient not only the insurance markets so that people don't avoid sick people but actually try to treat them, but we also have to change the way we pay for things, because right now the reason our quality is so bad is you make more money the more tests and the more gadgets you run, regardless of whether people get healthier or not.
So it's just automatically we assume the quality is going to get better if we have
Well, so there's Dr. Mark McClellan, and we're down to our last 18,000 of these, so I recommend them highly. We enumerate 15 or 20 different specific ways in which you would change the approach to how doctors and hospitals are paid. If you don't make it in their economic interest to change the way we provide health care, we will continue to have these value quality problems.
And as an addendum to that, I think we've worked together enough before that we sort of, this is an implicit agreement among us, and a mistake not to flesh it out for the audience. In some cases, we don't provide high-quality care because we don't know how. So among the very expensive patients in the United States are those in the hospital. So they're in a hospital setting. They have multiple problems. They might have a heart problem. They also have kidney problem. And they've got a bunch of different specialists treating them but not really talking to each other. And it's all done differently all across the United States. We have no clue what goes on out there. One of the goals of getting better information into the system is to find out, A, what's going on, and B, what works. And so implicitly, you're raising the quality of care as you do that.
I'm getting the time sign already, so I would just we'll go one answer per question. We'll try to do two more. Go ahead.
Great. My name is Hannah Pingree. I'm a state legislator in Maine, and I have also the battle scars to prove how difficult health care reform can be. I have two quick questions. One, how specifically do you see states being engaged? I know coming from a small, poor, rural state, it's going to be challenging for states to financially figure out how to participate in a healthcare expansion. My other, just listening to the dialogue, when I think about what's coming out of Congress, something that will potentially have taxes involved, will really put new insurance mandates on the insurance companies, make providers angry probably in a variety of ways. How do you see this being bipartisan? I mean, I'm very supportive of the work that's been done, but when push comes to shove in the House of Representatives, is this really going to be a bipartisan bill? From a state perspective, I don't care. I just want you to get something done. But when I think about raising taxes and doing some of the things that are going to have to be done, is there really a chance of this being bipartisan?
Well, that's a
I'll
good question.
just give a really quick question or answer. First of all, we recognize with the economic downturn that the states are in even worse shape than the federal government. States like Colorado, for example, can't even print money. So we're going to try not to put too many, unlike the federal government, we're going to try not to put too many burdens on the states. Secondly, with respect to the insurance companies, one of the great differences between this debate and the 1993 debate is the insurance companies are actually part of the discussion. I still don't know if this will be bipartisan. I hope it will be. We're trying to work on that every day. I'm working with my colleagues across the aisle. But there are some outside forces that are not just, I know you'll be shocked, that are not just policy-oriented around this. So we're going to keep trying.
Let's go to the last question over here.
I'm a physician, and I, despite what the Congresswoman says, I almost never see a patient who's satisfied or loves their health plan. On the other hand, the patients who have traditional Medicare are very happy with traditional Medicare. So my question is, assuming we could do the reforms on the delivery side, what's wrong with single-payer health care?
Doug? No one's you.
Well, I think the Medicare system is exactly the testament to why we have problems with it. I mean, I've said this many times before. One of the saddest moments in my CBO career was being at a witness table and having a senator ask me, what's the right price for inhalation therapy in Alabama? If you have a single-payer system, you will have politicians who cannot keep their hands off it. They will, in the end, do some price fixing, do some benefit favors, and end up with a system that is at cross purposes with the reform that you initially set out to have. And I view that as just an unmistakable truth about what we see in Medicare today. So I don't want to go further down that route. People deserve high-quality care, and the American taxpayer deserves more for their money, and that's where I'd like to go.
We're going to do a very quick lightning round of questions. I want one-word answers from everybody on the phone. No more than one-word answers. Here we go. It's December 31st. Has President Obama signed a piece of healthcare legislation?
Yes.
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 What is the issue? Wait, you haven't
Don't
heard
be
what's in
deceived
it.
by one-word
That's
answers.
Right. We didn't get to what's in it.
Yeah.
Are a large portion, let's say 2/3 or greater, give or take, of people without health insurance, do they get health insurance as a result of this act eventually?
Yes.
No.
Yes.
Yes.
What group that has traditionally fought healthcare reform proves out to be surprisingly the most hopeful in this endeavor?
Doctors.
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 Physicians, no question about it. No question about it.
And on the flip side, what group, that could be anyone, is most likely to derail this process? I'll start with Len.
Ideologues.
Republicans. Sorry.
Small businesses.
Voters.
Pretty big group there, Jason.
Is there a new tax of some kind and some form on health benefits when this is done?
Yes.
Yeah, I refuse to answer on the grounds it may incriminate.
You're allowed.
No.
Oh, interesting.
Yes.
And is it does the CBO score this program, the Congressional Referee, as deficit neutral over the 10-year window?
No.
Yes.
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 Okay.
It won't pass otherwise.
All right. Thank you very much, panelists. For those of you, I'll plug my own. I'm actually doing a talk on healthcare reform later today. Anyone else wants to come to that? And maybe I'll grab one of these guys to come by, too.